and very good afternoon. Welcome to the World Oral Day Talk Series. And today is the third day of the series and the last day. And we are starting a bit early today as we are getting slightly one more speaker than the first 2 days. Okay, to start the ball rolling, we have the first speaker, Dr. Venkata Bharatwaj. He is from Manipal University College, Malaysia. Dr. Venkata received his bachelor degree from MGR University in Tamil Nadu, India, and his master's dental surgery from SRM in Chennai. Has written over 150 papers and have about 118 citations. He is a driven competitive researcher, has been practicing medicine for more than 8 years. In addition, he has more than 6 years experience teaching in academia and has mentored a number of postgraduate and undergraduate research. He's currently the faculty as a faculty and member at the Manipal University College, Faculty of Dentistry. Today, Dr. Venkata will share with us on the topic, the dental treatments and prevention. Dr. Venkata, the screen is yours.
Thank you, sir. Thank you for your kind words, sir.
Welcome.
Good evening, everyone. So I am Dr. Venkata Bharatwaj from Manipal University College, Malaysia. So today my topic is on dental treatments prevention. So what is prevention? So prevention is nothing but a set of action that reduces or eliminate the chance of developing a disease by reducing the exposure to risk factors also. So it is nothing but a proactive approach that focuses on preventing dental problems before they arise. So it saves your time, money, and discomfort in a long run. And it also helps you to take control of your oral health and also an overall well-being for a lifetime. So what when proceeding to prevention, so what are the dental diseases that should be prevented? So one is called cavities or dental caries. The other one is gum disease, which is otherwise called gingivitis and periodontitis. These are the most commonly occurring oral diseases that should be prevented. So cavities is most commonly caused due to the plaque accumulation that eats away the tooth enamel, and gum disease also the same culprit is the dental plaque, which causes inflammation of the gums, and also eventually if the plaque is not removed, it causes a progressive damage to your supporting structures like bone and periodontal ligament. So before going into prevention, we should know what it is. So dental plaque is also called dirt or bacterial plaque, which is a filmy deposit on the teeth, on the surfaces of the teeth, and it consists of mucus, bacteria, and food. Whereas dental caries, it's nothing but tooth decay, which is a process of demineralization of the enamel. So the enamel is made up of minerals like calcium, phosphate, and other metals. So these minerals are demineralized by the actual destruction and also causes destruction of enamel and dentin with cavitation, leading to dental caries. So starting off with, how does this dental plaque cause these things? So dental plaque is nothing but it causes gum disease. So generally it starts with gingivitis, which is called the inflammation of your gums. So this will lead to periodontal disease eventually. So in early stages, the symptoms will be like redness of your gums, slight swelling and bleeding while brushing. So this rarely will cause also pain to your gums. So this plaque bacteria, when it stays long in your teeth, on your teeth, it eventually hardens by taking the calcium and phosphate that is present in your saliva and becomes tartar or calculus. So the plaque also penetrates into the roots, in the roots and deep parts of the gums, creating a pocket, and this will lead to bone destruction, which is underneath your teeth, inside the surrounding the root structures. So, if plaque is left untreated, these deep pockets will further exceed, and this will cause shaking of your teeth, and finally, the teeth will eventually be lost. Okay, so coming on to dental caries. Similarly, the plaque of the bacteria plaque will contain bacteria. Thus, that bacteria will react with the food that you consume day to day. And this, in turn, this reaction will cause a production of acid. And this acid will, in turn, cause breakdown of the minerals that are present in the outer structure of enamel in the tooth. So, this will cause holes or cavities on your tooth structure. Eventually, the enamel will bone away, and the bacteria can penetrate deep inside the underlying structures like the soft dentin and the pulp that is present inside the tooth. So this will again cause a serious trouble. So how this all reactions are taking place is that it is due to this simple concept called a triad or relation between uh, these models, this content that is present in these models. So this is nothing but a bird's eye view of your dental disease. So there is a microbial environment which is called the agent, and this microbial environment will transmit via the environment to the host. Host is the patient or us. Okay, so the host and microbe will interact with the environment, and this will happen in due course of time. So this time is nothing but the incubation period, or the time taken for the illness to occur or onset, or the time taken to for the illness to reach its highest threshold. So this time is the interlacing point between the host agent and environment, and this will eventually cause the disease to progress. So coming on to prevention. So how will you prevent this uh, disease? So mainly we consider four things. One is plaque control, the other one is fluoride treatment, the third one is diet control, as well as the regular dental visits. So starting off with plaque control. So mainly plaque control is done by the main tools of brushing, which is nothing but your toothpaste and toothbrush. So what is the correct quantity of toothpaste that you must take? So generally it is the pea-sized amount. That is the size of a pea will be the quantity of toothpaste for children above 3 years of age. If the children are less than 3 years, it might be a smear shaped or a rice size structure of toothpaste that is taken. So there is nothing harm in taking a little toothpaste, and it is not a criteria that the toothpaste should cover all the bristles and the quantity should be more to clear to cause even more better cleansing of the teeth. That nothing like that. So the size of the paste matters only in the size of pea size, not more than that. So using ribbon sized of toothpaste on a toothbrush will not cause any good for your teeth. Coming on to the brushing technique. We generally say to you, we generally suggest to use a modified bars technique for cleaning your oral cavity, which is nothing but a common brushing technique where you hold the toothbrush at a 45-degree angle, and you just use a back and forth motion and circular motion via on the gum line, and the bristles are then swept down towards the from the gum to the biting surface of the teeth. So towards the edge of the teeth. So this will cause a flicking movement or sweeping movement, and a vibratory motion is also added. So this kind of movement is called a modified Bars technique, and this is considered to be at least a 20 strokes per tooth is suggested to be a no optimum level of uh, brushing technique. So considering this, then we should go to the next step, which is nothing but the time to change your toothbrush. So when is the time to change your toothbrush? According to the Australian Dental Association, they suggest to change toothbrush at least 3 months or sooner than that. So if the bristles are frayed or flattened, or if it is worn out, it is better to consider it as the first sign of wear and change the toothbrush. There are also other signs and symptoms that your toothbrush is not worth or has undergone wear and tear, which is nothing but you might feel the teeth is still fuzzy even after you finished brushing, or you might have undergone some disease, or you might have been sick recently for a long time, and the toothbrush you use must be changed. The next is maybe the brush is having a bad smell or something, or you don't remember when you last changed your toothbrush. All these things are typical signs that you have to change your toothbrush. And even now, the many manufacturers of toothbrush suggest to you not to use toothbrush for more than 3 months. Then coming on to toothpaste. So everyone usually buys a normal toothpaste, but the thing that we have to consider is the active ingredient, which is nothing but the fluoride. So normally the fluoride content of a toothpaste will help the teeth to fight against the cavities. So the amount of fluoride that is present in a toothpaste is usually measured in terms of parts per million. So here, if it is given as 0.14 percentage volume by weight by volume, which is nothing but 1,400 parts per million. So usually the it is present on the sides of the toothpaste where the ingredients are present about the fluoride content that is present in a toothpaste, and the toothpaste should have minimum of 1,350 to 1,500 parts per million of fluoride for adults to use. Uh, Considering this, how this fluoride acts is that if normally the food and the bacteria react together and create acids, and this acid will cause cavities. But what fluoride does is it strengthens the teeth by uh, converting the normal crystals that is there in the teeth into fluorapatite crystals, which is even more stronger. The second thing is that uh, it prevents the mineral demineralization and promotes remineralization, that is deposition of more and more minerals, so that there is no cavities formed. And it also intervenes with the bacterial cell and tries to fight against it and kill mostly. So these are the advantages of using fluoride. So according to Australian Dental Association, they have also mentioned few recommendations for using toothpaste and toothbrush. So like for 0 to 17 months old child, the ppm should not exceed 500, and you can use it once the first tooth erupts. So the quantity must be like a rice trans size only, not more than that. Whereas for children more than 18 months to 6 years, you can use a pea-sized amount of fluoridated toothpaste, and the ppm should be 500, and smear layer should be 1,000 to 1,500. Whereas about 6 to 12 years, it is pea-sized, and 1,000 to 1,500 ppm of standard fluoride is used. And always, in whatever age it is considered to brush twice daily. And professional advice, that is higher concentration of fluoride, is given by professionals in dental clinics. And this concentration will reach up to 5,000 ppm also. So because that is given once in a while. Then coming on to the professionally applied fluorides. At home, the fluorides is mostly toothpaste, and sometimes based on your dentist recommendation, it can be even fluoridated mouth rinse. Again, which can be used only for children who are more than 6 years of age and not below that. And coming on to fluoride, professionally applied fluorides, which are nothing but varnished gels and topical fluorides, and these are applied on periodic intervals by your recommended dentists for moderate risk caries persons, not the low risk ones. So these are the ways by which the fluoride content is incorporated in your teeth, so that your teeth is even more stronger than it is to be. So apart from this, you also have other professionally applied fluorides like sodium fluoride, which is applied by paint on technique, and they just paint on your tooth. And acidylated phosphate fluoride is another fluoride which is applied using trace on your oral cavity. And you also can use varnish. So these are the fluoride inputs that you can take in for prevention of cavities in your teeth. Then coming on to diet. So in what ways diet will affect your uh, oral hygiene and your plaque accumulation, and eventually the caries formation and periodontal disease. So diet is nothing. This graph is nothing but called as Stephen's curve, which depicts the pH value of your saliva. So generally the pH should not go acidic. It should not be less than 5.5, which is the critical pH. So if the pH value is less than 5.5, your oral cavity is in an acidic state, and this will cause minerals to bore out. So usually, when you consume any form of fermentable carbohydrates, your pH value drops below 5.5, and it'll take at least 30 to 40 minutes to come back to a normally neutral pH level, or more than a critical pH level. So that is called a safe zone. So the acidic zone below 5.5 is called a critical zone or danger zone. So when you start consuming the snacks for longer time, or when you have frequent duration of snack consumption, then what happens is you are at a greater risk, because your pH keeps dropping below 5.5 repeatedly, and it has to be given time to come up about 5.5. So the recovery time is required, but which is not given by your diet. So this will cause you to stay in danger zone for quite a long time, and eventually cause dental caries. So there are few recommendations of foods that you can use for karyogenic, karyostatic, and anti-cavity. Like foods which are acidic in nature and sticky to your teeth are mostly caries causing food. So they cause caries more. Whereas karyostatic are vegetables and fat and high protein content foods, which stop caries progression and which are not caries causing. Whereas anti-cavity, which prevent caries formation, is the fresh fruits, green leafy vegetables, seasoned cheese, milk, and alkaline drinks without sugar. So mainly, this diet prevention works out when you consider only two things. One thing is the frequency of sugar intake and the consistency of the food. So WHO
Dr. Venkatesh, I hope you can speed up because your time is up actually.
yes, sir. Just two more slides, sir. That's all. Over.
Okay.
Yes, sir. So the sugar intake can be compromised by if you consider less than 10% of sugar intake in your food, and also avoid sticky foods in your diet. So the last thing is your regular dental checkup. So usually dental diseases are asymptomatic, or you will know the symptom only if it is too late. So when you cannot reverse, where you cannot reverse, so it is advisable to go and visit a dentist every 6 months, so that you get your professional recommendations about your oral hygiene, and also you can go undergo professional tooth cleaning frequently at 6 months interval, so that it will reduce the risk of dental diseases and infections, and will provide even more better breath for your oral cavity. And also, uh, dental diseases like malocclusion, which cannot be prevented and hereditary, but few environmental factors can be utilized to prevent malocclusion, which can be done only if your children are at an younger age with in contact with the dentist for a regular interval, so it can be prevented. So this also helps in regular dental checkups. And finally, dental procedures are always costly and complex and time consuming. So when you start delaying your treatments, it will obviously cost you money, whereas pain and higher risk of complications and infections, longer recovery time, and or fewer damages that can be repaired. So these are the disadvantages of delaying your procedures. So regular dental checkups will help you achieve this even more in a better manner. So I thank everyone for your time and your patient listening, and I hope this talk has been helpful for you all in many ways. And I'm happy to be a part of this World Health Talk series by Malaysian Dental Deans Council. And I would like to express my heartfelt thanks to my Dean, Prof. Abdul Rashid Sir, Malaysian Dental Deans Council, for giving me this opportunity. And I thank Prof. Dato Dr. Mohammed Ibrahim Abu Hassan for moderating my session. Thank you, everyone.
Thank you, Dr. Venkata, for the insight of prevention in oral disease.
Thank you.
Please stay until the end because if we have time, we might have some question and answer. Okay, Dr.
Thank you.
Venkata? Thank you very much. Okay. All right. Thank you. From prevention, now we move on to our next speaker. This is with regards to our next speaker is Dr. Fazlinda Baharin. She is a lecturer at University of Science Malaysia. She got a DDS from USM and then follow on to have an MSc in pediatric dentistry from University of London. Dr. Fazlinda, today, this evening, we share with us on the topic nitrous oxide sedation, taming the dental fears of young patients. Dr. Fazlinda, it's all yours now. You're muted, Dr. Fazlinda.
All right, sorry. Let
Yeah.
me share
Okay.
the screen okay, 1 second. Let me share my presentation. Right. All right, can you see my slide?
Yeah, good, very good.
All right,
Okay.
alhamdulillah. Okay. Thank you very much, Professor Dato, for your kind introduction. My name is Fazlinda Baharin, and I'm one of the pediatric dentistry lecturer from USM. So today I'm very fortunate to be invited to speak in this brilliant event organized by the Malaysian Dental Dean Council. And inshallah, today I will be sharing with all of you about nitrous oxide sedation, in which I believe it's a common thing for pediatric dentistry family, but I think it is a new information and knowledge to be shared to the public about this sedation that we always do on regular basis in our clinic. So throughout my presentation today, inshallah, I will cover the mechanism of actions, the efficacy and benefits, the patient selection and assessment, and also a little bit on the administration techniques. So regarding the nitrous oxide sedation, so in our clinical practice, why we need sedation for our children patients, because I think all of you know how challenging to have pediatric patients on the dental chair, ya, dan pesakit kanak-kanak mereka kurang memberi kerjasama. Jadi kadang-kadang untuk prosedur yang mencabar, kita perlu membantu pesakit kanak-kanak ini dengan memberi sedation. Yeah, there are many types of sedations in our clinic. There are where we administer the sedative drugs to different routes, from oral administration, inhalation, and we do have the intravenous and as well as the intranasal. Yeah, in USM we commonly practice the oral and the inhalation sedation. Yeah. So for today's topic, I will cover the inhalation sedation, in which we use the nitrous oxide gas. So what is the nitrous oxide gas? It is a colorless gas, mildly sweet smelling, it's non-irritant to tissue, and it's generally safe. It has the minimal alveolar concentration of 105. So the mechanism of actions, this nitrous oxide gas, it has the analgesic, anxiolytic and anesthetic effects, which means dia memberi kesan untuk mengurangkan anxiety, mengurangkan keresahan, kerisauan, dan dia juga mempunyai analgesic, yang itu mengurangkan rasa sakit, dan juga anesthetic. Dia boleh induce unconsciousness lah, a little bit of unconsciousness kepada pesakit. Gas nitrous oxide ini rapidly taken from the lung alveolar into the blood. Dia meresap dengan cepatlah daripada kita nafas tu, kita tarik nafas, gas itu dia meresap dengan cepat di dalam paru-paru, dan kemudian dia diambil oleh blood circulation dan menyebabkan kesan yang agak serta-merta. Kemudian apabila sudah berada dalam paru-paru dan menyebabkan kesan-kesan sedation, gas nitrous oxide ini dibuang daripada paru-paru dengan cepat juga. Sebaik saja kita berhenti memberi gas nitrous oxide ini. Jadi seperti yang di dalam slide, dalam gambar, this is the machine that we use in our clinic. There are two types of machine, the digital one and the analog. The digital, it needs the the electrical supply lah. Whereas the analog is the mechanical one, it doesn't need any electrical supply. But both works well. Jadi together with the machine, there are nasal hoods that come in different sizes. So you have to choose, boleh pilih saiz hidung pesakit lah. Jika hidung pesakit pediatrik kecil saiznya, dan mesin ini boleh juga digunakan untuk pesakit dewasa juga. Okay. Kelebihan mesin ini adalah dia mempunyai ciri-ciri keselamatan. It has its safety mechanism, yang mana we can titrate, kita boleh control gas sebanyak mana kita nak bagi, ya. Dan yang bagusnya mesin ini dia akan stop maksimum 70% saja nitrous oxide yang kita boleh bagi, ya. The sedation we give it nitrous together with the oxygen, so we always make sure that the patient receive minimum 30% of oxygen. That is the safety feature. If something happened with the machine, the oxygen drop and things like that, the machine has its own safety checks, that is just cut off the nitrous oxide supply. Jikalau digital machine, dia akan ada beeping lah, dia akan beeping alarming sounds saying that something is not right. So we have to stop the treatment and have a look what's going on. So going to the efficacy and benefits, like I mentioned before, why we give sedation to pediatric patients, because it is quite normal, it's quite common to have pediatric patient don't want to cooperative, sitting on the chair, even for a simple examination. It is very common for us pediatric dentists. So if we want to perform some procedure that might be challenging even to the adult patient, for example, dental extraction, you want to give in local anesthesia, ya, suntikan kepada pesakit. So to help them untuk relax, jangan gentar. So we give, that's why we supply with the sedation so that we can help the patient to do the dental extraction. So walau bagaimanapun sedation tidaknya sesuai pada semua pesakit. Still we have to select patients, okay? Because with careful patient selection, only the nitrous oxide oxygen station, it works well, it's successfully, it can in at least 90% of the patients. Nitrous oxide sedation, it has wide safety margins, with minimal effect on the heart and the respiratory function. Because when we talk about sedation, you can say whether this is a mild, moderate, okay, and it can go to deep sedation, and we don't want it if the patient falls into this unconsciousness, which general anesthesia. So with nitrous oxide sedation, it always has this mild to moderate effect of sedation. So it's safe. And also this sedation is more pleasant, more pleasant in a sense that we can do it in the dental setting, okay? In contrast to general anesthesia, there are more things to handle, more things to arrange, the ward admission, the liaison with the anesthetist, the booking of the operation theatre. So it's hassle. With nitrous oxide sedation, you can just do it in your dental office, and it takes about 40 minutes, and the treatment, inshallah, it can be done. So regarding the patient selection and assessment, to do sedation on patient, you need a relatively healthy patient. So if you have a very sick child with complex medical problems, it's better not to do it. You have to speak to the physician and do the proper referral. Okay, and then you need to have a patient which is mature enough to cooperate and understand. Meaning to say, if you have a 3-year-old, maybe very young, like 3 to 4, it's quite difficult because with nitrous oxide sedation, you need to put the nasal hood on dekat hidung. Jadi kalau pesakit itu terlalu muda, very young, then by putting the nasal hood pun mereka akan menangis. That is a challenge if you have a very young patient. So it's better to have, in my practice, I would always have 6 years and above. The school-going age children is better because they can obey command and they understand your instructions, and then the patient must be mild to moderate dental anxiety. Very, very anxious children, also you cannot do it because you need a little bit of cooperation from them to inhale the gas and exhale. So mild to moderate dental anxiety. And if simple procedure like examination, we don't normally sedate the patient. When you want to do challenging procedures such as dental extractions, then I think we can supply the sedation in an anxious patient. In certain medically compromised patients, such as in asthma patient, when they stress, sometimes that can precipitate their asthma attack. So yes, you can give the nitrous oxide sedation as well. Those patient which is needle phobic, have the pronounced gag reflex, can benefit from nitrous oxide inhalation sedation too. Right, the administration techniques. Before we do the inhalation sedation procedure, you need to have a written consent. Yeah, you need to speak to the parents and explain to them and get their sign the consent. Okay, and then with this kind of sedation, you don't really need to fast. Have a strict fasting rule. Just light meal 2 hours prior to the sedation. The operating staff must have a very good documentation and records. And also we need a responsible adult escort, yeah, to be throughout the procedure and to make sure that there is a parent or adult looking after the child at home. Right, this is the machine, digital machine. So how we do it, after we put the nasal hood, the nose of the patient, we give 100% oxygen first, okay? And then after we see the child can breathe in, breathe out, very comfortable, and we can slightly, slowly and increase, give the nitrous oxide gas incrementally, okay, until we keep on going up, 5%, 10%, 15%, 20%, until we can see the signs of sedation. So what is the sign of sedation? This is mild sedation, so the child should actually awake and respond to you. Okay, you cannot give the gas until the child like very very sleepy, that is too much sedated. Okay, so we always talk to the patient and we ask, what's your name, where are you now, and we always make sure the child respond to us. It's just as we keep on increasing the dose, the child will be still respond to you but a little bit sluggish. Okay, and you can see from their eyes, they blink less, and they kept like their eyes like staring to one spot, so this child is ready now. And you perform the procedure. Okay, you keep that sedation level, you perform the procedure, and once you complete it, you taper down the nitrous oxide and supply again 100% oxygen for about 3 to 5 minutes, okay, to flush out the remaining nitrous oxide in the system. So
I got 1 more minute.
okay, I'm finishing. Okay, this nitrous oxide sedation is the gas is not as potent as sevoflurane. It's very weak, so you always supply it with a non-pharmacological behavior. For example, you keep on talking to the patient, make them more relaxed, so you can keep the nitrous oxide gas to a very minimum level. And during the protocols, during the procedure, you have to do the monitoring. Okay, make sure you state the time and start and end of the sedation. The adverse effect of this drug is so minimal that if it'll take more than 1 hour plus, then the child can have a nausea, vomiting. And if it's a longer hours, it can cause the diffusion hypoxia and bone marrow suppression. But most of the time, you always keep the treatment procedure 30 minutes or 40 minutes. Okay, since this is, even though it looks simple, but in order to do it, you need a dedicated staff, yeah, because you need a proper training for maintenance of the machine and, together observing the child, especially intraoperatively, and also must be competent in CPR or basic resuscitation skills, okay, to stand by if anything, from unplanned deep sedation. Before I end the presentation, just a little bit of sharing clinical case. For example, this patient, 6-year-old with nephrotic syndrome, kidney problem, potentially cooperative child, but not very cooperative towards LA. So we able to take out that rotten teeth, 7.5 and 7.4 in 30 minutes. In children, it can take up to 1 hour to get them cooperate and get this tooth out. The same thing, 7-year-old, but fit and healthy. Okay, fit and healthy child. Again, able to get this teeth out in 40 minutes. So it works. It works. Yeah, with a careful patient selection, it works. So conclusion, nitrous oxide oxygen sedation has been widely used as an effective pharmacological method in dentistry for many years across the globe. A thorough understanding of its mechanism of action, indication, contraindication, the delivery techniques is important to ensure its safe and efficient administration. And also with proper training, the dental teams, I believe we can confidently provide this kind of sedation in a safe and effective manner. These are my references. Thank you very much.
Thank you very much, Dr. Fazlinda, for the very interesting presentation on nitrous oxide. It's not many times that our patient is aware about this nitrous oxide treatment available. But anyway, please stay until the end. Should we have any question, any of our viewers like to ask more about nitrous oxide. Thank you, Dr. Fazlinda. Okay, now we move on from preventive to pediatric and now orthodontics. Orthodontics, we have our speaker, Professor Dr. Aida Nur Ashikin from University Technology Mara. Prof. Aida is graduated from BDS University Malaya in 2004. She later obtained a qualification in Master in Orthodontics from UM also in 2011. Aida has an orthodontic educator since 2007, and she has also Master's Science in Medical Education from the United Kingdom. She specialized in cleft lip and palate as well as orthodontic surgery from Royal College of Surgeons of England in 2018. As she is also an international fellow from 2016-2018. Currently, Prof. Aida is the Dean of Faculty of Dentistry UiTM. Prof. Aida, the screen is yours now.
Assalamualaikum dan selamat petang. Terima kasih banyak Prof. Datuk atas pengenalan tadi. Izinkan saya membuat perkongsian saya mengenai rawatan ortodontik dalam bahasa Melayu. Jadi saya akan mengupas apakah rawatan ortodontik daripada frequently asked question atau soalan-soalan yang biasa ditanya mengenai perawatan ortodontik. Jadi apakah perawatan ortodontik? Rawatan ortodontik adalah dikenali sebagai pendakap gigi atau braces, adalah rawatan kepakaran pergigian ortodontik untuk mencegah atau membentulkan susunan gigi yang tidak teratur, jongang ataupun jarang. Di samping itu, rawatan ortodontik juga perlu bagi pesakit dengan masalah rahang tidak harmoni dan masalah kongenital seperti cleft. Rawatan ortodontik juga diberi bersama rawatan pembedahan rahang oleh pakar pembedahan mulut dan maxillofacial dan juga sering diberikan perawatan bersama dengan kepakaran pergigian yang lain. Apakah jenis-jenis appliance ortodontik? Terdapat beberapa jenis appliance tetap dan juga boleh tanggal ortodontik. Di antaranya adalah appliance tetap konvensional ataupun di mana kita boleh meletakkan modula getah di atas pendakap gigi ataupun bracket gigi tersebut yang dilekatkan pada permukaan gigi. Dan di samping itu juga terdapat appliance tetap self-ligating dan juga seramik yang di sebelah kanan, dan seramik braces seramik adalah lebih estetik dan tidak begitu kelihatan daripada persekitaran. Dan juga terdapat braces tetap yang diletakkan di bahagian dalam permukaan gigi. Selain itu, appliance ortodontik juga boleh datang dari segi boleh tanggal. Di antaranya ialah removable appliance yang dipakai untuk menggerakkan gigi secara transient ataupun appliance boleh tanggal yang digunakan untuk pesakit yang sedang membesar untuk dijadikan functional terapi ataupun terapi fungsi untuk membantu pembesaran pesakit. Di sini di sebelah kanan adalah appliance boleh tanggal yang Lucina dan juga adalah salah satu pilihan untuk appliance ortodontik estetik. Jadi siapakah yang perlu perawatan pendakap gigi ortodontik ini? Individu dengan masalah ketidakaturan gigi dan rahang dapat diindikasikan untuk mendapatkan perawatan pendakap gigi ortodontik dan sebenarnya tiada had umur, tetapi kesihatan gigi dan gusi perlulah berada dalam keadaan yang optimum dan sihat. Kanak-kanak juga mungkin memerlukan perawatan ortodontik, tetapi appliance yang digunakan mungkin berlainan daripada appliance yang digunakan oleh pesakit dewasa, seperti appliance boleh tangga atau appliance fungsi untuk membantu tumbuh sara mereka. Ibu bapa juga boleh membawa anak-anak yang masih mempunyai gigi susu sekiranya masalah gigitan dikenal pasti dari kecil. Ini adalah untuk mengelakkan persepsi ibu bapa bahawa sekiranya anak mereka masih mempunyai gigi susu, mereka tidak boleh mendapatkan rawatan pergigian ortodontik untuk kanak-kanak atau anak-anak mereka. Jadi antara masalah pergigian yang dihadapi oleh pesakit yang boleh mendapatkan perawatan ortodontik adalah masalah kesesakan gigi. Kalau dilihat di dalam gambar rajah ini, terlihat pesakit ini mempunyai kesesakan gigi atau ketidakaturan gigi yang sangat kompleks. Jadi pesakit ini perlulah mendapatkan perawatan ortodontik untuk menyusun atur gigi beliau. Dan selain itu, gigi jongang juga boleh dirawat menggunakan perawatan appliance ortodontik. Dan juga masalah seperti gabungan gigi jongang dan sesat seperti yang ditunjukkan di dalam rajah ini. Gigi jarang juga boleh dirawat menggunakan appliance ortodontik. Selain appliance tetap ortodontik, gigi jarang juga boleh dirawat menggunakan appliance boleh tanggal. Jadi sebaiknya pesakit yang merasakan gigi mereka tidak teratur ataupun jarang ataupun jongang pergi mendapatkan konsultasi daripada doktor yang bertauliah untuk mengetahui sama ada mereka layak untuk mendapat perawatan ortodontik. Di antara masalah lain yang pesakit yang boleh mendapatkan perawatan ortodontik adalah masalah rahang tidak harmoni. Seperti ditunjukkan di sini, rahang atas selalunya perlulah berada lebih ke hadapan daripada rahang bawah. Tetapi pesakit ini mempunyai rahang bawah yang lebih panjang daripada rahang atas. Di samping itu, pesakit ini tidak boleh menggigit di gigi hadapan dan hanya menggigit di gigi belakang. Jadi pengunyahan pesakit tidak ada optimal dan hanya boleh mengunyah menggunakan gigi belakang sahaja. Pesakit yang mempunyai rahang tidak harmoni. Contoh yang tunjuk di sini adalah pesakit yang sama di sebelah kiri mempunyai rahang dagu yang kecil, tetapi setelah perawatan dagu pesakit ini telah menjadi lebih normal. Dan pesakit yang ditunjukkan di sini sebelah kiri adalah pesakit ini sebelum perawatan, di mana dagunya adalah lebih panjang dan beliau juga tidak dapat menggigit makanan dengan sebaiknya. Dan setelah perawatan gabungan ortodontik dan juga pembedahan ortodontik, pesakit ini dapat berfungsi, giginya lebih berfungsi untuk pengunyahan dan pertuturan yang lebih baik. Di samping itu estetik yang lebih optimum. Jadi di manakah saya perlu dapatkan rawatan ortodontik? Rawatan ortodontik adalah rawatan kepakaran yang memerlukan perawatan dilakukan di klinik pergigian yang mempunyai pakar ortodontik. Walau bagaimanapun, sesetengah klinik pergigian am ada menawarkan rawatan ortodontik bagi kes yang mudah. Masyarakat perlu memastikan perawat adalah doktor gigi bertauliah dan dijalankan di dalam premis berdaftar sebagai klinik pergigian. Dan rawatan braces di premis haram kebelakangan ini adalah sangat berleluasa. Jadi masyarakat perlunya peka dan cakna bahawa rawatan ortodontik tidak sepatutnya didapatkan daripada spa, salon kecantikan, bilik-bilik hotel, rumah persendirian ataupun dipasang oleh individu bukan profesional. Sekiranya masyarakat ataupun individu itu kita dapati mencurigakan, sebaiknya jangan dapatkan rawatan daripada mereka. Dan sekiranya harga yang ditawarkan begitu murah dan tidak munasabah dibandingkan dengan klinik-klinik pergigian, jadi kita perlulah tahu mungkin dan bertanyakan kepada klinik tersebut atau premis tersebut sama ada individu tersebut adalah profesional pergigian atau tidak. Di sini tunjukkan rawatan braces di premis haram yang telah diserbu oleh Kementerian Kesihatan Malaysia, di mana perawatan ortodontik dijalankan di spa kecantikan untuk meletakkan braces. Jadi kesan buruk yang didapati oleh masyarakat, oleh individu yang memakai pendakap gigi oleh bukan profesional, yang dipasang oleh individu yang bukan profesional, boleh menyebabkan banyak masalah yang tidak lagi dapat dibantu selepas itu. Jadi sebaiknya untuk mengelakkan daripada kejadian tersebut seperti kerosakan dan penyakit gigi dan gusi, penggerakan gigi yang tidak diingini, risiko jangkitan silang kerana tiada alat pembasmi kuman di premis-premis haram, dan peralatan dan instrumen yang tidak renyah kuman adalah kotor dan mudah berkarat. Jadi di sini apabila kita meminum atau memakan makanan sejuk dan panas, proses karat itu akan lebih mudah berlaku, dan braces bukan dari grade perubatan yang mudah karat dan mengeluarkan logam berat ini adalah sangat berbahaya. Sepertinya nikel dan kromium boleh menyebabkan risiko kanser kepada pemakai pendakap yang dipasang oleh individu bukan profesional dan juga pendakap palsu. Di antara rawatan braces palsu yang ditunjukkan di sini adalah fake braces, ataupun mereka claim ini adalah real braces tetapi dia diletakkan di situ iklan-iklan braces murah ataupun dipasang oleh individu bukan profesional pergigian. Kalau dilihat di dalam platform dalam talian di Malaysia, fake braces dijual dengan berleluasa, dengan murah dan harga yang sangat mudah mampu milik. Tetapi semestinya masyarakat perlu peka bahawa ini bukanlah rawatan braces yang sebenar, dan sekiranya pesakit perlu mendapatkan perawatan braces, sila dapatkan daripada klinik-klinik yang berdaftar. Kerana sekarang sudah menjadi trending untuk memakai braces di sekolah dan sebagainya, ibu bapa perlulah memeriksa sekiranya anak mereka memakai braces dan tanya dari mana mereka mendapatkan rawatan tersebut, kerana ditakuti anak-anak mendapatkan braces daripada premis-premis haram ini. Okay. Faedah perawatan ortodontik. Faedah perawatan ortodontik yang sebenar ataupun yang dipasang oleh profesional, dia adalah untuk mengembalikan fungsi gigi dan rahang yang optimal seperti mengunyah. Jadi pesakit dapat makan dengan baik, bertutur dan bersosial, dan penampilan diri. Apabila penampilan diri bertambah baik dan estetik bertambah, psikologi pemakai akan lebih baik. Dan kesihatan pergigian dan kebersihan gigi juga mudah dilakukan seperti flossing, memfloss dan juga memberus gigi untuk mengeluarkan kekotoran di dalam mulut. Dan juga di samping itu, memakai braces juga dapat menyokong struktur wajah dan menambahkan estetik ataupun mengekalkan estetik wajah. Okey, fungsi yang optimal dan estetik, contohnya saya ingin tunjukkan di sini kes-kes yang telah dirawat dan bagaimana perawatan ortodontik dapat memberikan faedah yang telah saya senaraikan tadi. Okey, di sini tunjukkan pesakit ini menggigit terbalik ya daripada gigitan hadapan beliau, dan setelah perawatan, okey, ini adalah gigitan tidak normal, dan setelah mendapatkan rawatan yang menggunakan fasa appliance ortodontik boleh tanggal dan juga pendakap gigi tetap. Jadi pesakit ini telah pun mendapat gigitan yang cantik dan fungsi dapat dikembalikan kepada optimum dan ideal. Ini adalah pesakit ini selepas perawatan. Untuk psikologi, senyuman yang menawan dan keyakinan diri, kalau dilihat gambar di sebelah kiri dan kanan adalah pesakit yang sama sebelum dan selepas perawatan mendapatkan perawatan ortodontik. Inilah pesakit sebelum pembedahan dan pesakit selepas pembedahan bersama perawatan ortodontik. Fungsi pertuturan dan pengunyahan dapat dikembalikan. Contohnya pesakit di sini mempunyai gigi yang tidak pun tumbuh dan juga gigi yang hilang. Jadi selepas dirawat ortodontik, beliau lebih yakin untuk bersosial dan mengembalikan fungsi pengunyahan beliau. Dan di samping itu, pertuturan juga dapat dikembalikan dengan baik kerana sekiranya mempunyai ruang di hadapan, pertuturan setengah huruf itu tidak dapat berjalan dengan baik. Okay, dilihat di sini pesakit sebelum dan selepas perawatan ortodontik. Ini adalah pesakit tersebut sebelum perawatan di mana gigi beliau tidak keluar walaupun beliau sudah berumur 16 tahun. gigi itu tersekat di dalam rahang, jadi menggunakan perawatan ortodontik gigi tersebut ditarik dan diluruskan. Ini adalah pesakit tersebut selepas di hujung perawatan ortodontik. Untuk mengembalikan kesihatan kebersihan gigi, kalau dilihat pesakit di sini mempunyai masalah kesesakan gigi yang sangat kompleks dan juga di samping itu beliau mempunyai masalah gigi jongang. Jadi selepas perawatan pesakit mempunyai gigitan yang lebih optimum dan gigi yang tersusun atur. Okay, di sini ditunjukkan perawatan pesakit ini yang melalui fasa twin block dan juga headgear. Headgear adalah salah satu peralatan yang juga digunakan untuk perawatan ortodontik. Headgear itu adalah yang ditunjukkan gambar di bawah yang dipakai di kepala dan juga di mulut. Okey, untuk menyokong struktur wajah, kalau dilihat di sini pesakit ini adalah pesakit yang sama. Baju hitam adalah sebelum rawatan dan baju hitam dan putih, kola putih adalah pesakit selepas perawatan. Dilihat senyuman pesakit ini semakin baik dan juga rahang pesakit ini telah pun kembali ke normal selepas perawatan ortodontik. Dan ini adalah pesakit tadi sebelum perawatan di mana beliau mempunyai gigitan yang tidak normal dan jongang dan juga ketidakaturan gigi, kesesakan gigi yang sangat kompleks. Selepas perawatan ini adalah gigitan pesakit tersebut dan gigitan beliau adalah lebih tersusun atur. Pesakit juga mempunyai keyakinan diri yang lebih baik. Jadi saya merasakan perawatan ortodontik ini telah membantu beliau dalam memberikan faedah-faedah bukan sahaja dari segi estetik tetapi juga dari segi psikososial dan juga keyakinan diri. Kesimpulan untuk perkongsian saya adalah rawatan ortodontik adalah perawatan pergigian bagi pesakit dengan masalah pergigian tidak teratur dan pemakaian appliance ortodontik sudah bertambah. Memandangkan kesedaran kesihatan pergigian di kalangan masyarakat kita sudah semakin baik dan pesakit perlulah mendapatkan rawatan ortodontik dari profesional bertauliah. Faedah mendapatkan rawatan ortodontik adalah untuk fungsi yang optimal, untuk fungsi pengunyahan, bertutur dan kesihatan pergigian yang optimum serta estetik wajah. Jadi dari situ saya ingin mengucapkan terima kasih kepada Dean Council, kepada Kementerian Kesihatan dan terima kasih juga kepada Prof. Datuk Muhammad Ibrahim Abu Hassan kerana moderasi perkongsian saya ini dan juga sesi ini. Terima kasih banyak.
Terima kasih, Profesor Aida. I know the fake braces is your favorite at heart topic to talk. I harap you will touch on fake braces. It's very important for the public to know about fake braces. I guess there should be a question at the end about fake braces. Maybe you would like to stay behind until the end, Prof. Aida?
Okay.
Okay, thank you.
Yes, Prof. Datuk. Thank you very much.
Yeah, thank you very much, Prof. Aida. And now we move on to our next speaker. And then we go on to another discipline now. This time in restorative, we have Dr. Faiza Abdul Fattah from USIM. Dr. Faiza is a clinical lecturer in Department of Conservative Dentistry and Prosthodontic, University of Science Islam Malaysia. She is currently the Deputy Dean of Academic International since 2019. She obtained her Doctor of Dental Surgery from UKM in 2003 and completed her specialist training in Master in Restorative Dentistry from Newcastle in 2011. Her interests include dental materials, restorative dentistry, as well as dental education. Lebih kurang sama dengan saya, Prof. Faiza. Okay, today Dr. Faiza will share with us on the topic choosing the right path, direct versus indirect restoration in restorative dentistry. Dr. Faiza, siap.
Terima kasih Prof atas introduction yang diberikan. Assalamualaikum warahmatullahi wabarakatuh diucapkan kepada semua. Izinkan saya pada hari ini untuk berkongsi sedikit ilmu berkenaan dengan restorative dentistry dan semoga perkongsian pada hari ini dapat memberikan sesuatu yang bermanfaat buat semua. So tajuk saya pada hari ini adalah choosing the right path, direct versus indirect restoration. So saya akan pakai kedua-dua bahasa bagi presentation pada petang ini. So as a introduction, kenapa kita memerlukan restoration? Sebenarnya tujuan kita membuat tampalan ataupun restoration ni adalah untuk mengembalikan fungsi, bentuk dan juga estetik kepada gigi tersebut. Dengan adanya juga advanced modern teknologi dan juga materials yang available dalam market, so kita dapat menawarkan kepada pesakit dan juga pengamal pergigian pelbagai pilihan untuk mengembalikan ataupun membuat tampalan bagi mencapai function estetik dan juga more natural look. So what are the current ataupun kenapa kita sebenarnya memerlukan rawatan restoratif? So jika kita melihat sebenarnya faktor utamanya adalah caries. So jadi kalau kita lihat daripada sumber Pusat Informatik Kesihatan Kementerian Kesihatan Malaysia pada 2023, di sini data menunjukkan sebanyak 74% pelajar 12 tahun adalah DMFX, mencapai DMFX 0. Ini menunjukkan masih ada 25% pelajar yang mengalami ataupun experience caries jika dibandingkan dengan pelajar berusia 16 tahun. So hampir 40% masih lagi mempunyai masalah caries. Jadi kalau kita lihat faktor yang kedua adalah disebabkan tooth wear ataupun tooth surface loss, hakisan gigi. Okay? Jadi hakisan gigi kalau kita lihat pada masa kini makin kerap berlaku, di mana banyak ianya boleh disebabkan oleh tabiat memboros gigi yang tidak betul ataupun mungkin disebabkan parafunctional habit seperti bruxism. Tapi yang saya rasa yang paling jelas sekarang ni adalah semakin ramai yang clench daily. Something yang selalunya pesakit kita tidak aware, tapi kalau kita sebagai pengamal dapat mengesan, so bila kita inform our patients, makanya clenching can be controlled. Jadi kalau mengikut daripada kajian telah dilakukan oleh Halim et al, prevalence berlakunya general tooth wear adalah sekitar 99.8% bagi 16-year-old adolescent in Kuantan, manakala untuk erosive tooth wear sekitar 45%. Sebab ketiga adalah trauma. Jadi apabila berlaku trauma menyebabkan gigi kita patah, maka perlulah tampalan dilakukan. Selain daripada trauma juga disebabkan oleh crack ataupun fracture tooth sendiri. Jadi berdasarkan National Oral Health Survey of School Children 2017, sekitar 7.2% pelajar berusia 12 tahun mengalami trauma pada gigi anterior. Next one is disebabkan permintaan estetik lah, dan saya rasa pada masa kini lebih banyak kes-kes ataupun permintaan daripada pesakit sendiri untuk memperbaiki senyuman masing-masing ataupun memperbaiki bentuk gigi supaya mendapat senyuman yang lebih menawan. Makanya aesthetic concern adalah satu demand yang menyebabkan tampalan gigi diperlukan ataupun restorative treatment required. So apakah what types of treatment available? So directly adalah restoration. So restoration adalah in definition is to bring back the physiological and mechanical functions, and then kita dapat mewujudkan balik ataupun bring back the anatomical forms, and then we can ensure that there is a good occlusion, dapat mencapai occlusion yang lebih baik ataupun mengembalikan fungsi occlusion supaya pesakit boleh mengunyah dengan lebih baik, dan preserve a good contact point. Dengan adanya good contact point, kita dapat prevent daripada masalah makanan melekat, food trap dan sebagainya, dan akhirnya kita dapat mengembalikan estetik. So restorative treatment sebenarnya boleh dibagikan kepada dua. It can be divided into two, direct and indirect. So direct restoration ni adalah selalunya dilakukan kepada gigi yang mengalami kehilangan struktur gigi yang kecil ataupun tidak kompleks. Ianya selalunya dilakukan secara direct, maksudnya pesakit datang ke klinik, kita lihat, kita rawat dan terus boleh restore, kita boleh menampal gigi tersebut. Tapi namun dengan adanya adhesive dentistry yang semakin berkembang pesat and also minimally invasive approach, that's why I would say direct restorative approach is more preferable. Dan maksudnya kita dapat dapat memastikan the restoration that provided has a more promising result. Untuk direct restoration, there is a few ataupun many materials available seperti tampalan komposit, amalgam dan juga hybrid material such as RMGIC, compomer dan geomer. Okay. Jadi kalau kita melihat dari sudut kebaikan direct composite, so saya akan lebih fokus kepada composite kerana composite merupakan satu pilihan tampalan ataupun materials yang sangat digemari oleh not only pesakit tapi patient tapi juga oleh pengamal pergigian pada masa kini. So if it has a proven with a good success rate, minimally invasive approach, sangat cost effective, boleh mengembalikan, I think can bring back the aesthetic because composite ada banyak selection ataupun a few selection of shade available in the market. Increase patient and operator satisfaction, tidak memerlukan no laboratory fee or minimal material and equipment cost, boleh reduce the micro leakage occurrence disebabkan oleh teknologi ataupun advancements of adhesive dentistry, and then low thermal conductivity. Kita command setting di mana apabila kita place the material, kita can directly cure it, tak perlu tunggu lama. Easy to repair, let's say kalau ada berlaku deficient, even staining without any caries involvement, kita boleh repair or kita can easily replace. Accessibility for pulp testing because direct composite dia tak cover banyak sangat struktur gigi, maka jika gigi tersebut memerlukan ujian, maka pulp sensitivity test can be done. It's a metal free, kurang berlaku endodontic complications kalau kita compare dengan indirect technique, and reduce the risk of catastrophic failure. Macam contohnya pesakit memang ada tooth loss, jadi dengan adanya direct composite teknik ini kita dapat menghalang daripada hakisan gigi ataupun tooth loss itu berlaku dengan lebih teruk. And then also reduce dental legal. Okay, so ini adalah contoh di mana sebenarnya pesakit ada veneer yang telah pun ada defect. Jadi kita boleh menggunakan teknik restoration untuk mengembalikan kembali fungsi dan juga estetik tersebut. Okay, sekarang we move on to indirect restoration. Okay, what is the meaning of indirect restoration? Is the restoration that fabricated outside the tooth. Maksudnya pilihan untuk rawatan ini memerlukan fabrication of the restoration di makmal ataupun di luar daripada clinical settings. So the clinical indication biasanya kita lakukan indirect restoration ni pada cavity ataupun jika melibatkan kehilangan struktur gigi yang agak ekstensif, large and complex, and then we can also do indirect restoration for replacement of large compromised existing restoration. Dan repeated fracture restoration, kalau pesakit datang ke klinik mengadu tampalan saya kerap pecah, patah, so that's the indicator of having indirect restoration. And then if let's say following endodontically treated tooth, and then the tooth required cusper coverage, so kita memang highly suggest to do indirect restoration. And lastly, aesthetic consideration requested by the patients. Okay. Baik, ini contoh-contoh gambar. So, what is the type of indirect restoration? Crown, bridge, inlay, onlay, and veneers are among the types of indirect restoration. And then untuk indirect restoration sebenarnya terdapat lebih banyak pilihan materials available Maksudnya kita boleh melihat kepada keperluan pesakit dan kita mungkin faktor-faktor lain yang boleh mempengaruhi dan finally kita boleh decide. So untuk indirect ni banyak pilihan rawatan bergantung kepada accessibility ataupun availability materials dan juga equipment yang diperlukan. Jadi ini adalah contoh-contoh teknologi dan juga materials yang boleh dipakai untuk indirect technique. So apakah advantage? What is the advantage and disadvantage? For advantage of indirect technique, it improves physical and mechanical properties. It has good wear resistant, variety of materials and techniques available yang boleh dipilih that can be choose by the clinicians. It can reduce polymerization shrinkage in terms of when we are using composite, indirect composite, definitely can control the polymerization shrinkage of the composite itself. More precise control of contours and context because kita ada technician has a plenty of time, kita boleh check occlusion, kita boleh carve and then cast everything so that kita can bring back a good anatomical form. Less technique sensitive than directly placed composite restoration is referring to indirect technique. Biocompatibility and good tissue response. Okay, and then for the disadvantages, increased cost and times. It require multiple visits, necessity of temporary restoration. So kalau selalunya dealing with temporary restoration ni sometimes mungkin ada risiko pesakit temporary restoration tertanggal ataupun fracture ataupun ada foot trap dan sebagainya. Bonding difficulties in certain cases, especially dealing with the subgingival cases ataupun PrEP, technique sensitive laboratory procedure. So therefore kita memerlukan juru teknologi yang berkebolehan lah, yang ada skills to produce a good crown, bridge, inlay, onlay or veneers. Brittleness of ceramics, especially kalau kita pakai when we are using feldspathic type, and difficult to repair untuk ceramic and materials. But there is available materials, but sometimes dia still susah untuk dilakukan in certain conditions. So the complications of indirect restoration is, according to articles, there is a prone to secondary caries, 1/3 of all failures. Ni banyak contributing factor, either the PrEP itself ataupun patient's factor, so dia ada banyak possibility. High incidence of iatrogenic damage to the tooth and adjacent teeth, so this is due to the clinician itself, so kita kena avoid doing any iatrogenic damage because as we know, when we do a crown prep on the vital tooth, there is a risk of the tooth become non-vital about 40%. Okay, so be careful. Increased risk of endodontic pathology, increased risk of periodontitis, connective tissue damage, and tooth loss. Related to perio, as if let's say our preparation itu is disturbing the biological weight, it's too subgingival, it can also increase risk of perio disease. Subgingival margins are commonly associated with gingival recession, tooth wear of opposing teeth by ceramic restoration. So that's why kalau kita, when we are issuing the crown, when we do some modification of the crown, best is to polish as good as possible because ceramic definitely can abrade opposing tooth, especially if it's a natural tooth. So that's why the best practice for before cementing the crown or ceramic crown itself is by doing a final glaze. But if let's say in your setting there is a equipment, okay, radio opacity obstruct radiographic monitoring, okay, kalau especially when the core is the metal type, bila kita ambil x-ray definitely kita tak nampak the structure inside. And then is also for crown and bridges, memang dapat kita upon investigation, let's say the tooth is vital, patient come with a complaint, memang kita tidak dapat melakukan ujian vitality kepada gigi tersebut. Okay, and also there is an increase of dental legal risk. So these are example of cases. So just I just want to at least refresh back ataupun memberi sedikit apa tu peringatan untuk kita semua sebagai clinician dalam kita design our crown and bridge, especially associated with the long span bridge. Kita perlu make sure that the design is something that feasible for the patients to clean. Sebab at the end of the day, how good your crown and bridge are, kalau patient tak dapat mengekalkan kebersihan yang baik on the surrounding crown and bridge, definitely is going to fail. Sebab itu the conventional design of link crown, link bridge ni harus kita berhati-hati elakkan, kerana selalunya abutment yang berada di tengah-tengah akan bertindak sebagai fulcrum dan ianya akan selalunya fail. Apabila ianya fail, ia akan start to fracture ataupun debond, and then kalau kita ada more than apa tu link tooth yang tooth that act as abutment, so dia akan berpindah kepada gigi bersebelahan until the last standing one tu yang fail, barulah bridge atau crown bridge itu akan tercabut dan result kepada gambar yang ditunjukkan ini. So please be careful. So direct versus indirect restorations. So what to choose? So it definitely is depend on clinical situations, and then we also need to assess the availability and accessibility of the materials and equipment in our clinic. Okay, and clinicians should always take into consideration the advantage of both direct and indirect restoration, then weigh against the disadvantages. So I think I'm sure by apa tu experience, when we look at cases, we can choose the right materials. Okay, so the choice of
Faizah, panjang lagi ke?
sikit je lagi, doktor. The choice is depending on the financial feasibility, time involvement, and physical properties. Okay, so this is just a quick suggestion. So before kita, we have to consider the case selection factors, and then also there is a few questions that need to be asked ourselves before kita deciding to do either direct or indirect technique. So as for conclusion, the advancements of technology and the variety of dental materials provide benefits in selecting the treatments. However, each case has its own unique needs that must be carefully evaluated to identify the causes, requirements, preference, and expectations. Regardless of the treatment provided, it should be carefully considered to align with clinical indication and ensure the preservation of tooth structure without compromising the outcome. So additionally, it should be ensured that the restoration has a good success rate for the benefit of the patient. Therefore, I thank you, Prof. Terima kasih semua kerana meluangkan masa untuk mendengar. Sekian, terima kasih.
Thank you very much, Dr. Faizah. Terima kasih kerana telah berkongsi tentang restoratif, indirect dan indirect. Kita ke pengakhir program kita petang ini. Sebelum saya introduce speaker terakhir, pada siapa yang join kita petang ini, ada link untuk kehadiran sertifikat, saya share dalam chat. Sila isi dalam Google Form tu kalau nak ada setnya. Okey, seterusnya kita ke penceramah kita yang terakhir, last of the series. Kawan lama saya sebenarnya, saya tak tahu juga yang dia ni pernah jadi kapten dalam angkatan tentera semasa dia berkenalan dengan dia dulu. Okey, bila tengok CV ada pula kapten Bersara Prasemadya Dr. Farid Sheikh Ghazali. Dr. Farid adalah Associate Professor Farid, field specialist in oral surgery, human anatomy and histology, and high resolution microscopy and microanalysis. He has teaching experience of 33 years and has been a plenary and invited speaker at International Microscopy Conference, Asia Pacific, and European Microscopy Conference. He's Myra Gold Medalist Specialist and recipient of Pencipta and Malaysia MTE Exhibition Award. Dr. Farid is currently at Lincoln University College. Today, Dr. Farid will share us the topic on oral maxillofacial surgery, maxillofacial injuries and also oral cancer perspective. Dr. Farid, it's all yours.
Thank you, Dr. Prof. The topic for the day is about the perspective of the oral maxillofacial surgery in relation to the oral cancer and maxillofacial injuries. The moving the regarding this oral maxillofacial surgery, this is an internationally recognized surgical specialty which deal with diseases, conditions, and injuries of the mouth, jaw, and until the various structures of the neck and its associated structures. This is a branch of the surgical expertise that is evolving, and various techniques have been introduced to make this scope of practice as an educational process that is ever changing. To have a glance of what it is, it involves from dental surgery, cleft surgery, the temporomandibular joint disorder, implantology, congenital cranial malformation, and the craniofacial pain. For oral maxillofacial surgery, this whole entire profile of a cadaveric structure involving the maxilla, the mandible, and laterally here, as you see, part of the parotid gland pre-aurically can be seen are all major structures related to various disease acquired or congenitally by a patient that need to be treated by an oral maxillofacial surgeon. Per se, there has been a gradual increase in total attendance of oral maxillofacial surgery patients in the last few years. In 2014 to 2018, there was about 3,680 patients seen. In all oral surgeries cases, in 2018, 73.7% are of minor surgical cases, whereas these minor surgical cases are of pre-prosthetic and pre-orthodontic procedures. Other procedures involve removal of impacted tooth, the excision of malignancies, and various routine root removal. Major surgery at that era was of 26.3%. Here, there is a lookout of a cleft palate involving both the lips into the hard palate. Major cases, which is considered minor, involve the dental surgery related to the third molar tooth. Third molar tooth is called the wisdom tooth and is located at the posterior aspect of the mouth. And they are considered impacted, as seen here in various angulation, because they have not enough room within the mandibular bone or body to emerge or grow normally. Here we can see that there is association of the wisdom tooth with various radiolucency, and we can see that why? Because most of these 25% of wisdom tooth patient, they have perceived themselves actually as asymptomatic patient, but however, they are usually feel or presented with various inflammatory periodontal diseases. This is why, because the oral cavity harbors or is a medium for a diverse ecosystem of microorganisms. They are full with Streptococcus, Protavella, Prophyphalis gingivalis, Fusobacterium nucleatum, and Actinomyces species. Furthermore, but basically, some of them are inflammatory, but majorly they are oral normal flora. They are basically because some of them are gram-positive bacteria and can lead to progression of periodontal or chronic periodontitis gum disease. And most of them, like this Veillonella, is found because it is needed for the maintenance within the oral cavity. Over here is a montage of various of these bacterial regime that can be found within the body, within the oral cavity, sorry. Pertaining to oral cancer, we need to know that the oral cavity is very needed for breathing, talking, chewing, and swallowing, and they refer to a lot of anatomical structure from the mouth to the throat, including the lips, and into the tongue and floor of the mouth. Above, you will find the hard palate, which is the very bony part, and posteriorly, the soft palate. Here you can see the whole, or what is called a proper oral cavity, And you can see that here we have the soft palate. Oral cancer is significantly a public health concern worldwide. In Malaysia alone, oral cancer remains up to the top 20 most common cancer with a 5-year prevalence of 2,199 cases. Most worryingly, the incidence of oral cancer is expected to be projected to a double value by the year of 2040, following the local age-specific incidence and population. The oral cancer alone is one of the most common cancer in the Asian region. Importantly, if we look at the latest WHO data published in 1920, Malaysia oral cancer reached to about 1,865,000 of the total population that is of total death. With this kind of age-adjusted death rate, Malaysia is now ranked at 27 in the world for the presence of oral cancer death. You need to know that there's a mirage of diagnosis for oral cancer coming from leukoplakia, erythroplakia, very scary, the submucous fibrosis, and lichen planus. Why all this have happened is because many different cells are involved or differentiated. They undergo a process of transformation without normal physiological control. And the ability of this is to spread further into remote areas of the body via the lymph nodes, and this can cause very detrimental presentation. Per se, a lot of symptoms, sinus symptoms can be presented in a mouth cancer. You can see that if you have a lump, you have complaint of loose teeth, you have changes in your vocalization, speech, you have bleeding and numbness of the tongue, are some of the sinus symptoms that can run. Of these sinus symptoms, it was diagnosed that in the United States alone, 55,000 cases was observed in 2022. As mentioned just now, most of this oral cancer arises from squamous cell epithelium or squamous cell epidermal cell that line mostly of the proximal gastrointestinal tract, which is the mouth, the tongue, the gums, and the lips. These are actually because of the keratinized cell of squamous cell epidermal, they are squamous cell carcinoma. Here, it differs if we were to consider solid gland cancer, because this is more edematous or actinous-derived cells. Very importantly, a diagnosis had to be specified, and this involved physical examination and majorly we will do a biopsy. Once biopsy is established, this has to be stitched to determine the extent of the condition. And this will be helped by special investigation. This include CT scan, MRI, and PET scan. Treatment for squamous cell carcinoma depends on various factors, such as the staging itself, where it is anatomically located, and the overall health of the patient. And various region of mixed and individual treatment from radiotherapy, chemotherapy, or a combination of these can be referred to. However, the prognosis of this squamous cell carcinoma still depend on factors seen at the diagnosis, the effectiveness of various treatment that is provided, and the overall health of each individual patient. But whatever is the etiology as known from the squamous cell epithelial cell, something that increases the chances of getting the oral cancer is risk factor. The risk factor can be from gender-related, tobacco users, age, or even excessive sun exposure in a country like Malaysia in tropical. Very well known is from the sexual transmitted viruses and awakening of the immune system of the body. In Malaysia, there are few things that the manifestation of the oral cancer are related or can be based on. The challenge is because usually in Malaysia, or even globally in some other countries, late diagnosis of the oral cancer and late awareness about signs and symptoms limit the access to healthcare. This is very important because this will cause difficulties in management and treatment. Even dietary habits, which include the consumption of preserved and pickled foods, can contribute to the development of oral cancer. As mentioned just now, prolonged exposure to sunlight, and can cause again oral cancer. Even we have a significant infrastructure in our country, there are still disparity in attempts to access of healthcare for urban and oral cancer in pertinent to this, or the urban and oral rural pertinent to this oral cancer. And where is long legacy is the adaptation, the belief or cultural practice, such as in traditional medicine and reliance on conventional old traditional medicines. As mentioned, squamous cell carcinoma can present at the lips, tongue, the gum, palates, even at the floor of the mouth, can be associated to the salivary gland or the parotid submandibular gland, the oral pharynx. An example here, we can see that in a 59-year-old lady, you can see that the patient was presented with a painless mass at the left posterior mandibular margin, and the diagnosis was a verrucous carcinoma. Here we have simple, most Asian can be found at this area towards the buccal from the body or the ridge of the vestibule. This is the leukoplakia. And most of them is on the lateral aspect of the posterior 1/3 of the tongue. This is very scary to look and even know that on this buccal chip associated to the parotid duct area, we can see the oral squamous cell carcinoma, and need to know that 40% of this intraoral squamous carcinoma begins on the floor of the mouth or even at the lateral and ventral surface of the tongue. Of these, 38% occurs in the lower lips and mostly related, as mentioned just now, by the sunlight. In pertinence to another agenda, that is the maxillofacial injuries, we are going towards maxillofacial fractures. It's very important that this kind of fractures is a consequential condition as the result in mortality, severe morbidity, and facial disfigurement. The incident rates in Malaysia for a fracture that is defined as a broken lower jaw can have a very high incidence of towards 51.2%. And in a review that most of about 13,000 patients, there is a four-fold higher incidence of mandibular fracture in nearly 50% that is arriving from assault cases. And in women, 20% of mandibular fractures of the maxillofacial injuries are women, and these are secondary to falls, although domestic violence did show some contribution, but we need to really define that fractures, whether it's associated to mechanism towards accidental trauma. Thus, an evaluation, diagnosis, and management of this fracture remain very highly challenging. Although there is improvement in the imaging technology and various management such as the fixation techniques. But most importantly, the initial ABC of the management must be attended to. Problems with airway obstruction, major hemorrhage, even cervical spine injury, and intracranial injury must be the first line of management. As mentioned just now, patients with mandibular fracture can come with mandibular complaint of mandibular pain.
Dr. Farid, can you wrap up in 2 minutes because time is running out?
Okay, I'm sorry for this. I will try to wrap up. And because of that, it can lead to malocclusion and this facial asymmetry in a deformity situation. Over here we have an a PA of the skull and an OPG that reflects the asymmetry that occur post a maxillofacial injury. Okay. The management will need, as mentioned, surgical airway if there is obstruction, and basic if it is clean and consider mucosa or gingiva, we will give antibiotics. Tetanus prophylaxis will be needed, and the normal main control regime. There are various management. I'm trying to fill up that now. I'm almost finished. That for the completed fractures, most of them are treated with maxillofacial fixation, which is done for a period of something 6 and 8. But there's a danger because this kind of fixation is a poor choice for a malnourished patient. Thus, per se, what is the prognosis of mandibular fracture? Well, those who have suffered this, actually, the prognosis is quite good. But there are complications such as abscess and malunion. That's why, as an evolving oral maxillofacial surgery knowledge-based program, there is a need of innovation, research, and development, because all of the data that can be derived from all this intervention can contribute to development of various strategies that will help in the treatment of it. That is my Lincoln University, and that was me when I was younger. Thank you very much. I'm sorry for this. Thank
you very much, Dr. Farid, for the explanation on our cancers and trauma. Okay, we have come to an end of this webinar series. organized by Malaysian Dental Deans Council for the last 3 days in the conjunction with World Oral Health Day. And it's about 7:20. And I also see in the chat box there is no questions. So from any of our viewers, maybe because it's time for iftar. But anyway, on behalf of Dental Deans Council, I'd like to thank all our speakers this afternoon, Dr. Venkata from MUCM, Dr. Fazlina from University Science Malaysia, Professor Dr. Aida from University Technology Mara, Dr. Faiza Abdul Fattah from USIM, and finally, Associate Professor Captain Basara Dr. Farid Sheikh Ghazali from Lincoln for sharing with our viewers this afternoon. And overall, our last 3 days, we have 13 speakers from all the various universities who has come to share with us, with all our audience today on the 3 separate days. So we hope that this event is helpful, fruitful, and knowledgeable for, especially for the public who has joined us to listen to our webinar series in conjunction with Oral Health Day. Again, on behalf of Malaysia Deans Council, on behalf of the chairman, I would like to thank you all, the part speakers, and also the organizing committee who has worked very hard in a very short time. Actually, within 1 week, have come out with the list of brochure, the link, all the 13 speakers with the videos. It takes a hard work, especially in this past 6 months. And then thank you very much. And hopefully, all the effort that we have put in will able to contribute to better oral health for the Malaysian public, inshallah. So again, thank you very much, and to all our speakers. Okay, and since we do not have any question, yeah.
Here.
Sorry. Yeah.
Dr. Mahindran.
Yeah, reminder. You want to sometime?
Yeah. Yes, I wanted to find out about this illegal dentistry that's been, all these things that's going on. What are we doing to put an end to it? Because I find that people are able to buy brackets online and treating patients and all. How can the universities combine and work and bring up this issue to the ministry to put an end to all this rubbish? Because I think it's going out of control nowadays. A lot of people are going on YouTube, learning alternate treatment and coming out and treating patients. I think something has to be done where universities can combine, talk to the ministry, how they can work and put an end to all this rubbish.
Thank you, reminder. I think just now Professor Aida has touched about fake braces. So that is part. Okay, I think the most important thing is how to combat against the illegal practice of dentistry. The best thing is we, the university, Ministry of Health, and also MDA can work with the TV where they have more viewers. If you have any specific time in the air or TV time, then it'll be more effective to inform the general public the importance of illegal what is the consequences of illegal dentistry. So I guess, Mr. Dr. Mahindran, I think we can work further on this. I think maybe webinar might not be interesting because not many general public will listen to webinar. But if we go on TV, that will be more effective. That's the thing. I think MDA, the dental school, and also KKM oral health program can work on to combat this illegal or fake dentistry in Malaysia. I think that's my view. I think you on behalf of the MDA and also I on behalf of the Dentist Council, and we can work up together. If we can have a slot with any of the TV channel, I think it'll be more effective. We can work on that way. Dr. Mahindran. Okay. Thank you very much again to all. And I know, Dr. Mahindran, you have been joining us for the last 3 days. I heard that always you have something to ask our speaker. But anyway, thank you very much. We take note about that, and we, on behalf of the university, we will work with other agencies like MDA or other Ministry of Health to fight on illegal dentistry. Thank you very much. Until then, we'll meet again, inshallah, next year. And selamat berbuka puasa to all our Muslim colleagues. I thought we have also for today we have for the last 3 days I can see audience from even Sumatra, USU, who has joined in to listen to our speakers. The Dean of USU has also joined in when they look at the list of who are joined to see our webinar. Thank you very much, Tidan. We meet again next time. Thank you on behalf of Prof. Zamri, the Chairman of the Council, for all you to have joined this 3 days webinar series. Although the time is very tight because between 6 to 7 and on this fasting month might not be but because we want to coincide with the World Oral Health Day. Okay, thank you and see you again maybe in different platform, different program in future. Thank you again to all our 30 speakers for the last 3 days. Thank you.
Thank you.
Thank you, Prof.
Thank you.
Hi, Prof.
Thank you,
Selamat
for
buka
speaker, for
puasa.
staying until the end.
Thank you, Prof.